Well, thanks, Kieran. And it's a real honor to be able to speak to this group who are, by the work you've already completed, really committed to improving the knowledge base on which we make decisions to treat patients. I think everybody who's on this august group of individuals could give this lecture because you believe in the scientific method and you believe that this difficult work is important to make our care of patients better as we move forward. But I'll just go through a brief review um, with some examples of how scientific method through the ages has really helped to improve outcomes. So you'll recall that up until about the 1770s or 80s, physicians and barber surgeons used to do bloodletting to make patients better. You'll recall that the first president of the United States died with appendicitis because he had bloodletting, and some case series were done to eliminate that uh, procedure. I just completed a review of the life of Mozart, and he had eight children, only two of which survived because in the late 1700s, it was thought that the way you deal with newborns is to give them water, not mother's milk. And of course, we've eliminated that from our care. You will know the story of Semmelweis, who eliminated postpartum infections by the simple intervention of washing of hands with a case control approach, which eliminated that uh, real problem. Of course, Pasteur identified the microbiome as being important in the source of infection. And then population-based research, really good early on experience is John Snow, who was in London and identified by group case identification of uh, infection related to cholera and eliminated the problem by removing the pump handle, which was a contaminated water source. So that was a great example of public health as a scientific method. This is one from my early years of training. When I was a young surgeon and working in Seattle, it was thought that uh, cardiac arrhythmia after an acute myocardial event was something that we needed to stop. And a drug that prevented PVCs was lidocaine, and it made great sense. And it wasn't until a randomized control trial with the EMS system identified the fact that the mortality was higher after administering lidocaine than without lidocaine. So a real advance of the scientific method for a very common problem. And then, of course, in our field, the fact that intramedullary nailing was a superior method of treating femoral shaft fractures initially and all long bone fractures later on, which is something I lived through as a young surgeon. When I came to Vanderbilt in 1985 as the first orthopedic trauma surgeon, all femoral shaft fractures were being treated in traction in those days. So just goes to show you how old I am. So why is evidence-based medicine important? Well, there are five levels that I'm sure everybody on this call is aware of, and I just want to make the clear point that all of the levels have value. It's just uh, the importance or the value goes up as we climb up the scale from level 5 to level 1. And we have the group at Oxford and the group at McMaster to thank for bringing the world into the evidence-based method era. And what the system is set up to do is to inform us as consumers of scientific information of the issue of bias. And as we climb up the scale from level 5 to level 1, there are guide rails which are increasingly more effective to limit the bias that we have as particularly as surgeons. I think because of our basic nature as surgeons, which when you think about it is a really unusual characteristic, we are really not normal people. The ability to cut another human being on way less than perfect information makes us more prone to bias than I think other physicians. And it's something that I've gained a great deal of insight into why it is why it is that I am the way I am. And most of you on the call are also falling into that basket of weird people that can cut another human and make critical decisions and accept the outcomes. So, and it's this bias that is the most important enemy of progress. And I will just point out that all of us have heard our mentors say, in my hands, quote unquote, or what I see in my practice, quote unquote, is based on really, really bad information because based on our nature as surgeons, we remember the disasters we've seen and we remember the really good outcomes we've seen. And those really influence our impressions. And we often fall into the trap of feeling that we know what our outcomes are. And I would just point out to the group that unless we systematically are following our patients to gain longer term outcomes, we really don't know what the impact of our interventions are, thus the need for the scientific method. So again, I want to emphasize though that all levels have value. It's just the degree of value as we go up the scale. So these are important considerations. I spent the first 10 years of my academic career as a basic researcher. When you're working with animal models, you can control a lot of variables with genetic variants under control, with genetically identical animals, etc. Well, humans are not like that. And we have this very, very important confounding variable of the patient who has by nature various medical confounders, various psychological confounders, various social environment confounders that we need to always understand that they influence our outcomes. And we should do our best to try to control for these, thus the level 1 studies being the best approach whenever it's possible to do so. It's also important in our field to understand that performance bias is a really big deal. I have heard colleagues throughout the 40 or so years of my career quote to patients Joel Mata's results as an acetabular fracture surgeon. Well, those are Joel Mata's results. Those are not your results. And unless, again, you are systematically following your own complications and your results, you need to understand that there are indeed master surgeons and that some procedures are more technically demanding than others. And as we consider how to study surgical interventions, we need to do as best we can to control this performance bias. And that'll be part of the discussions in your various groups. Another unfortunate thing that we have to consider in our field is conflict of interest. Many of our colleagues are the inventor of implants, and they have secondary gain as a part of it with financial interests. And we must always put this in the back of our mind when we're considering results. Almost all top-level journals ask individuals to declare these conflicts, and you should be aware of them. And I will just say as a point of perhaps consideration for younger surgeons, I have never had a royalty on any surgical product, even though I've participated in the design of them. And I think it's a dangerous track to go down personally. And I think you should carefully consider it before you get off into that line of work. So this is my final slide. You all are incredibly aware of this triangle, again, brought to us by our colleagues at McMaster and Oxford. There is some value in level 5 evidence with an experienced surgeon, particularly one who knows the literature and who knows the levels of evidence that are embedded in those different literature citations. There is a lot to be said for 30, 40, 50 years of clinical experience with the caveat that you have to really take it with a grain of salt unless the individual has been really, really thoughtful in terms of the diagnosis or problem or intervention they're speaking of. Retrospective case series are something we are always going to be needing in our field of orthopedic surgery. I frequently have discussed this internationally. There will never be a randomized controlled trial done on anterior cruciate ligament ruptures in patients with rheumatoid arthritis. It's just too rare a condition that the numbers aren't there, multi-center, international, etc. It's just not going to happen. So what we need is carefully done retrospective casework that hopefully will build upon a prospective registry or prospective multi-center study to understand the outcomes of interventions. And I would want the audience to hear that, in my view, prospective research is always better, emphasize always better than retrospective research, because you can record variables that impact the outcome that you often cannot identify in chart reviews or record reviews. Case control is the next level where we have a control cohort that goes along with the intervention cohort, and we can compare outcomes, again, controlling for those confounding variables as best we can across all the different types. And then prospective cohort studies, as I've already mentioned, are ones that limit bias to a greater degree. And then we have at the pinnacle, the randomized controlled trial, which is the best as far as limiting bias. And we should always look carefully, and as editors of journals, we always look carefully at the elements of blinding, of assessment of outcomes across all these levels. You really want to have an individual who is not affiliated with a trial or a prospective cohort study, examining the patient, recording range of motion, obtaining the patient-oriented outcome measure to limit the bias to the greatest degree and increase the utility across our worldwide environment. And lastly, meta-analysis, which at JBJS, we have limited the use of that term for the compilation of studies that are done with randomized trials as the inclusion for those data sets, not the term systematic reviews, which adds data from non-randomized methodology. So that's my comments. I believe, if I understand, Kieran, there was some time for some questions or discussion. But again, I think this is very, very basic stuff, and all of the people who are here participating in this course are committed to the scientific method and improving the knowledge base on which we treat our patients. Thanks for asking me to give this introductory remarks, Kieran.
Thank you, Mark. Really great lecture, great way of framing today's discussion. Yes, we have a few minutes for questions, if there are any questions from any of our participants. I guess I have a question for you, Mark. You've laid out the levels of evidence, and I think you made a very important point that all levels of evidence are useful. I think that's certainly true. In my practice, the level 5 evidence I get from my senior partners has certainly helped me in the care of my patients, as has the level 1 evidence that I've read. A lot of the participants today are coming from resource-limited settings where outcomes are very difficult to follow because patients are lost to follow-up. The resources to support patients, to support research, are not often there. Do you have some advice for many of our colleagues here today about how to navigate some of those challenges and still produce worthwhile research that has value at the global scale? Because I know that JBJS has published many papers from around the world and supported surgeons from resource-limited settings and telling their story. So what is it that JBJS really looks for in those journals, and how have you seen surgeons from these resource limited settings navigate these challenges to be successful?
Well, I think the best models is partnership with individuals who are on the faculty, many of whom in this particular course, to partner to work through the difficulties of identifying, recruiting patients, obtaining appropriate ethics approval, and doing the very, very best they can to follow patients. And there have been some really innovative methods designed by some of the names of people I saw in the breakout groups to follow these patients. So collaboration with individuals who have access to more resources to help get around these hurdles has been very, very productive. But in my view, it's true in the developed world as in the developing world. Nothing trumps, hate to use that word, um, nothing substitutes for an individual that's committed to finding out an answer to a clinical question. And it's persistence. It is battling against discouragement when you have difficulty recruiting and following patients that wins the day every time. It's individuals committed to finding an answer to a clinical question that is the most important thing, regardless of what resources they have at their disposal.
I would agree with that, Mark. The commitment is key. And the other small point I would add to that is start off on the right foot. Designing the study right at the very beginning is essential. There's no real way to salvage a poorly designed study when you're in the analysis phase. So start off on the right foot, start with the right partnerships, design the study properly, think about things like ethics and equipoise and confounders, and how you're going to manage follow-up before you even begin data collection. And that's how you can really be successful, I think.
Sounds like a great advertisement for this course.